how I treat myeloma from my perspective. And myeloma is a field where there are a lot of drugs and a lot of different ways to manage the patient. So you'll get one perspective. Later on, we can have a nice discussion how you may want to differ from the way I recommend a patient to be managed. So I just wanted to reiterate that the way we understand multiple myeloma is that actually it's like multiple diseases under one diagnosis, because we clearly know that multiple myeloma, there is a hyperdiploidy clone with the origin, which is hyperdiploid, and then the other one is the non-hyperdiploid, and yet we treat them both in the same way. On top of it, we now know there are multiple clones at the time of diagnosis. And why this is important, that tells you that we want combination therapy. So whether we want 2-drug, 3-drug, etc., if we understand this is multiple clones at diagnosis, and biology dictates that combination would be better. Then different clones emerge over time, and what does that mean for me? If I had treated a patient with a proteasome inhibitor-based therapy, if they relapse, I may want to go to immunomodulatory drug. So it kind of helps you that which way we want to manage the patient when they relapse. There are driver mutation that holds promise in personalized medicine, but if you go back to the first statement, there are multiple clones. Even these driver mutations may only address a subset of the patient. They may have a response, but it may not be as durable. And finally, minor drug-resistant clones may become lethal. That finally, like in many other diseases, it doesn't matter hematologic or non-hematologic, once you have deletion 17p and the other one is also mutated, basically no longer has a 17p function, they become drug resistant and you lose the battle to myeloma. With that as a backdrop, we have many ways of analyzing the patient. People also send patients sample to Foundation Medicine, etc. You get all these different mutations we talk about. What does that really mean? You can use it as a prognostic. Certain mutations, IRF4, EGR1, may be prognostically useful. The other one, biallelic events, as I told, deletion 17p as well as TP53 mutation on the other allele, or another one is the FAM46C. Those ones, the patients hardly live 6 months or so once that has happened at a median time. So they are really bad prognosis. But there are some genetic lesions, and there are drugs which are approved for other diseases. So if you do get an information, you have the opportunity to use, because it's not necessarily evidence-based. I'd rather talk to you offline. Now, how do we want to treat a patient at this time? So this paradigm has not changed very much, rapid deployment of forces, consolidate your power, then try to maintain peace. That still holds true in this era. And in the elderly patient, since we don't use high-dose therapy, we do initial therapy followed by maintenance. But all of this gives you the feeling that there is a kind of a continuous therapy for minimum of 2 or 3 years for multiple myeloma. This is not like lymphoma, 6 cycles, complete remission. You look for molecular complete remission and you stop therapy. So that's important. Now, how would you manage? Then you have 3-drug combination. You can use 3 different drugs, but typically it's an immunomodulatory molecule, proteasome inhibitor, glucocorticoids. But in the future, it could be quadruple therapy too. And then, of course, you have to tailor the therapy according to the patient's age. So once we have this broad principle, then the rest will kind of flow. So you have all these choices listed here. I don't have to go through every one of them. But typically, what is your goal when you treat a patient? One is rapid and effective control of the disease and reduce early mortality and to reverse disease-related complication. In myeloma, this comes into play patient who presents with renal impairment. those who have severe renal impairment. Then you want rapid reduction of the tumor. You want to use drugs which are independent of the kidney function, so you're not dependent that you induce toxicity. So proteasome inhibitors, cyclophosphamide, thalidomide, corticosteroid, and adriamycin or Doxil. These 5 drugs are all very good for patient who presents with severe renal impairment with very high light chain. Patient with hypercalcemia renal impairment is different, which we can handle with appropriate hydration, bisphosphonate, and things like that. And now you can use denosumab also if you don't want to use Zometa for these patients. So rapid and effective control is important, but it is not very important in myeloma because not everybody presents that way. As a matter of fact, we pick up patients much earlier in the disease course. Deep and durable response is important, and we'll talk about it. Now we are talking that we are able to achieve, complete remission, MRD negative status. So that is something new because we are able to reach that status. So if I look at it in the era of Sid Salman and Bob Kyle, we never even had a definition for complete remission. Then Bart Bolagi and the transplant era, we started having complete remission. Now with the novel agent, we do have molecular complete remission. So because the therapy has improved, we can talk about how to use it. But all of them, we have to improve the performance status and quality of life. Now, from the introductory slide, you would know 2 drugs versus 3 drugs. Now we don't have to use Vincent Rajkumar's algorithm, little m smart, big M smart, whatever. You could be just smart and use 3 drugs and be done with it. Okay. Then the question is, can we achieve higher depth of response? You can now, and if you use proteasome inhibitor instead of bortezomib, if you use carfilzomib, then now evidence shows that you are able to get a greater depth of response, more complete response if you combine it with the stem cell transplantation. But at the end of it, even with all these 3 drug combination, you could see that only half of the patients go into clinical complete remission. And now if you go to, multi-parameter flow cytometry for minimal residual disease, only the more sensitivity it is, more difficult it is to show that they are all achieving that kind of a remission. So you can see next generation sequencing. Among the patients who are in complete remission, half of them still have minimal residual disease. So 25% of the patients are going into real MRD negative status with available therapy at this time. That may change once we start using additional agents like monoclonal antibody, but just to put it in perspective. But the good news is that we can achieve higher depth of response and complete response in substantial number of patients. And if you combine it with stem cell transplant, you can improve it even more. Why is depth of response is important? You could see that it definitely improves the progression-free survival. That's for sure. The complete, but whether they would be cured is a different question. And when do we test for minimal residual disease is important. If the patient has gone through induction stem cell transplant, then you do the bone marrow at day plus 100 and you find out it is MRD negative. We don't have to do maintenance therapy. Will it not? That is not true because those patients still all relapse. But if the patient is 3 years down the line and is still in MRD negative complete response, then those patients, a substantial proportion of them are cured. So not only achieving MRD, but sustained MRD is necessary for myeloma. That's why the continuous therapy is still important as opposed to lymphoma or other diseases where you do MRD and you say, okay, it's time to stop treatment. Then the question always comes, what about transplantation? So since I've been doing this stem cell transplant with Bart Bolagi in early days, 1980s onward, the question always comes, can we get rid of the stem cell transplantation? But high-dose melphalan is used now with the novel agent. There is no alkylating agent. Then high-dose melphalan is used From our total therapy eras of 1989, 1990s, we do know there is a subgroup of patients who are being cured, and we are still seeing those patients 25 years later who have been cured following the tandem transplantation on total therapy 1. So there is a subset of group who do benefit from that. So as long as you balance both arms for the same level of exposure to all the novel agent, then you add in one arm high dose therapy and stem cell transplant, that arm will always come out ahead for progression-free survival. And in some cases, even overall survival, but it never gets inferior. So at this time, I think the stem cell transplant is still recommended, and we'll go through a couple of those studies. But once we start having even monoclonal antibodies up front, and then we are able to show sustained molecular complete remission with these maneuver, then we will know who does not need stem cell transplantation. So this is Michel et al. They did the IFM Dana-Farber trial, which is still ongoing in the United States, so to speak, but majority of the patient, over 700 patients have already been treated, between RVD arm and transplant arm, and it was already presented in ASH, shows that the transplant arm has better depth of response and improved progression-free survival. But at 4 years at this time, we cannot really show that there is an improvement in overall survival. Then there was this ASH presentation, and that's important, the stamina trial, because this answers a slightly different question. This is transplanters, BMT, CT, and so, everybody gets at least one transplant. So induction therapy followed by one transplantation. Then the patients are randomized into 3 different arms. In one arm, they will get another transplantation. So the tandem transplantation as in total therapy, followed by maintenance. Another one, they get what is considered as consolidation, that was brought in by the French and the European investigators, that after transplant they should go through consolidation and then go through maintenance. So that particular question was asked. And then finally, just straightforward, let's go to maintenance therapy, as most of us have been practicing. And the good news is we will find out that there was no difference in the progression-free survival at 38 months between any of these 3 arms, or a difference in the survival. So at this time, one auto transplantation is important, as I showed in the earlier trials, and then maintenance is important. As long as you're doing that, I don't think the second transplant and other things are very critical at this time. And this one again highlights the same thing. This is Palumbo's, which is a good one. They did induction RD, then MPR versus 2 transplantation, maintenance, no maintenance. So you do 2 transplant and maintenance, they do much better. If you do 2 transplant and no maintenance, they become equivalent to continuous maintenance therapy with MPR. And if you do just MPR and no maintenance, they do worse. So this kind of tells what I was saying, bullet 1, bullet 2, bullet 3, as an illustration. Then we are all very familiar that the maintenance after transplantation with lenalidomide is good. It improves the progression-free survival. It showed improvement in overall survival only in USA, but not in France. So this was also well known, but then subsequently a meta-analysis was done, pooling both of these data together, and it was reported by Phil McCarthy in ASCO, showing that if you combine them all, that after 7 years, you could show that there is a survival advantage to patients who went on the maintenance. So it is always, my feeling is, this is nothing new in this. The general principle in oncology is, when you get to treat a patient, treat them with the best possible therapy up front. Don't let them relapse and then say you will capture it back. So if you lose that principle, I think that's what this one shows, nothing more than that. So there is a 26% reduction in risk of death, representing an estimated 2.5 years increase in median survival. Okay. The next important is patients who are elderly, but they are not going to go through transplantation, Again, they should be on induction therapy. The initial therapy should be at least 9 months to 12, and then they should be on maintenance therapy. And this is what shown here. First trial in RD continuous versus only 18 months or MPT. Then you have the MPRR continuous as opposed to MPR only or MP. And MPV was 18 months treatment strategy. So whenever you give treatment for a longer period of time, it always benefits is shown in multiple myeloma. So continuous therapy gives better outcome, length of induction 9 to 12 months, and adding proteasome inhibitor increases the depth of response in these patients. Then the question is, should we tailor the therapy? Should we tailor the therapy according to the genetic risk, age and comorbidities, severe renal impairment? Severe renal impairment, by definition, because of the drugs that you can use, you have to be conscious. They should be renally cleared. So as I said, proteasome inhibitor, especially bortezomib, cyclophosphamide, thalidomide, and of course adriamycin is also, or doxil is also independent of the kidney function. So those are good. And genetic risk category, I don't know whether if you're going to use all three drugs, triple therapy, there's nothing more to do anything risk. It's more prognostic. You have to be aware and follow them closely. You cannot change it. So it is not like in leukemia, it is 15-17 translocation, it's a 821 translocation, or it is a CML that you're going to choose the drug. It's still you have the same therapy. So that leaves us with age and comorbidities and paying attention to the kidney function. So the first trial I thought was a good illustration. It was well-designed trial because the lenalidomide dose was adjusted according to the age of the patient and the creatinine clearance of the patient, and the dex dose was adjusted according to the age of the patient. So if you do like that, then you saw in this international randomized trial, patient under age 75 and over age 75. What is remarkable is overall response rate is virtually identical. I mean, we are talking about 75 and older, response rate are virtually identical. And on treatment for more than 24 months, you could see that patients over age 75 were able to stay on the therapy, provided you paid attention to the drug dose and to their kidney function. So I think tailoring therapy to the age, their performance status, the frailty, and things like that. And of course now daratumumab has come, after sprinkling something, you can always claim he's resistant and you can introduce daratumumab very early for this patient, And we in myeloma, we have been taught about that. When lenalidomide was introduced, they will say a couple of doses of dexamethasone because after one line of therapy, they can get lenalidomide. So we have been through that. I think daratumumab is almost the same. It is relatively well tolerated. When you start seeing, now I'm seeing patient 91 and 96 parents, or bringing them in. It's well tolerated. That you should keep in mind. But anyway, that's not evidence-based. I suppose I had to be careful.
I want a future patient who's 91 who's bringing their parents in.
No. The parents of the family, bringing them in. Sorry. What do you expect from an Indian giving an English talk? All right. Now, geriatric assessment, then you can do the fit and all those things, I leave it up to you. That it predicts for the survival. So, in conclusion, all I wanted to say is continuous therapy improves outcome in both the transplant setting, you want the maintenance, and then for the non-transplant setting, continuous therapy improves outcome. Please keep that in mind. Prognostic factors are evolving as new drugs come in, but we still cannot do anything about it yet. Aim for deep and durable response, and that is important. Tailoring therapy and supportive care, please don't forget. But there, nobody giving bone health and infection, etc. So what's new before I completely get off? There are a lot of new activities, so I wanted to say myeloma is still a fertile ground for new drug development. And so that is very important. But a couple of things caught my thing. So we heard about venetoclax and how fantastic it is and things like that. So we myeloma doctors look at it. Let's grab it. Let's bring it into myeloma too. So we have, selinexor, venetoclax, things like that. But there was also another one from HIV drug, nelfinavir. So these were all presented in ASH. So the next 3 slides I will show them because venetoclax is approved, nelfinavir is of course approved long time ago. So in myeloma, the good thing now is a lot of drugs are approved for other diseases with which you can tinker around. So here is the selinexor selective inhibitor of exportin. And if you block the exportin, basically all the tumor suppressor protein stays in instead of being shuttled out, etc. Then the cell can undergo apoptosis. Nice cartoon, I like it to show every time. And there were 2 different studies, one using selinexor in combination with carfilzomib in relapse and refractory. So these are all called, this new things is to say quad refractory. That means they have been exposed to proteasome inhibitor, immunomodulatory molecule, and there are 2 proteasome inhibitor, 2 immunomodulatory molecule, and then penta, which is the daratumumab inhibitory. And this drug still works for them. One is selinexor plus low-dose dexamethasone in quad refractory, and in penta refractory, this combination still works very well. So we have to watch for this drug's development further. Then venetoclax is another drug, but in myeloma, BCL2 doesn't play a role except for 11-14 translocation, especially the subset of patients who express CD20 on their surface. There venetoclax alone works and puts them into complete remission within a matter of 2 months. So it's a very effective drug. And those who do not have that subset population, MCL1 is upregulated myeloma. That's why venetoclax fails. So you can give it along with proteasome inhibitor, bortezomib. The reason I'm saying is that, we are still not curing myeloma. A lot of patients are progressing and dying. So in your practice, this is something you may want to keep because you have a lot of experience using venetoclax. And I have not titrated it slow because I'm waiting for a tumor lysis in this relapsed refractory myeloma. I have not titrated, went straight to 400. Nobody has gone into tumor lysis. But anyway, if you want to titrate it, it's fine. Then comes nelfinavir, which is a drug proteasome inhibitor. The way it works is it's almost like the HDAC6 inhibitor talk Ken Anderson gives. One is you have the autophagy mechanism. Even if you inhibit proteasome, the cell can survive, and that could be blocked by the nelfinavir. This was a trial completely done by an investigator in Germany, spending his own, because no drug company will sponsor the clinical trial because there is no market for it. But he did show activity even in patients who had already failed proteasome inhibitor. I'm just throwing it out because these are all things we could make a big difference in patients' life. So I hope I gave you just a broad overview and some drugs that if you want to try on the side, waiting for evidence-based medicine some days, but you have access to those drugs. And I'll stop here.